This lecture is named for Dr. Roger T. Sherman to honor his contribution to the Congress, the field of surgery and trauma. Dr. Sherman became a member of the Congress while still a resident, and he presented one of the first gold medal forum papers. He was president of the Congress from 1984 to 85, and he was the secretary director in 1986 and served in that capacity until 1993. Dr. Sherman was Whitaker Professor of Surgery at the Piedmont Hospital and Emory University School of Medicine when he retired in October 1997. He died on April 9, 2006, at the age of 82. It's a great pleasure and honor to welcome Dr. Meyer to the Southeastern Surgical Congress. He is the Jane and Donald D. Trunke Professor, Vice Chair of the Department of Surgery at the University of Washington, Surgeon-in-Chief at Harborview. He completed his general surgery residency at the University of Washington and a postdoctoral fellowship in immunopathology at Scripps in La Jolla. He's currently president of the American Surgical Association and president-elect of the American College of Surgeons. He has served as past president of the Society of University Surgeons, Shock Society, AASD, Halstead Society, and the Surgical Infection Society. He is past director and chair of the American Board of Surgery. He's received numerous honors, including the Scientific Achievement Award from the Shock Society, the Lifetime Achievement Award in Trauma Resuscitation from the AHA, the France Carl Award from the American Surgical Association, the Parker J. Palmer Courage to Teach Award from the ACGME, the Sheen Award from the ACS, and provided the ACS Scudder Oration on Trauma and the AAST Fitz Oration. He is a member of the Gold Humanism Honor Society. He's an elective fellow of the American Association for the Advancement of Science. Dr. Meyer has been interested in the critically ill surgical patient in the aberrant host immunoinflammatory response and subsequent multiple organ failure. He's been funded continuously by the NIH since 1981. His interest in trauma has been involved studies in the acute management of the severely injured and impact of the trauma system on development on outcomes. He has delivered more than 400 lectures and 400 peer-reviewed articles and more than 60 book chapters. Dr. Meyer, please join us on the podium.
Good morning, everyone, and thank you, David, and the organization for this great honor. It's a pleasure to be here. I've never been to the meeting, but it's an outstanding meeting. The involvement of the youth in the organization going all the way back to Dr. Sherman is obvious and a phenomenal strength to the group, I believe. I am going to change directions dramatically here. I would like to say that I unfortunately agree basically with what Dr. Feliciano was saying previously. The only other thing I might add before I leave your topics is I think in today's world, you can also just put in drains and packs, get a good night's sleep, and then come back and do the Whipple rather than do the Whipple at 3 a.m. We found this is a little easier on the burnout rate of the surgeons, and the patients seem to like it better too. But those are great cases. What I would like to do is use this opportunity to take you on a sprint tour through a totally separate subject, which is genomics applied to trauma, which is something that's not done very much. It's a expanding field, and I'll try and show why we believe this is important and relevant. I have nothing to disclose. Again, it's an honor to present this lecture named after Dr. Sherman. As you just heard, he is an amazing individual who is part of the core of this organization for many years, and it's a pleasure to be here. So this is our old paradigm, which we used for 30 years to get funding from the NIH in trauma. And basically, it's focused on the, It's focused on the concept that when you have a major traumatic episode, the innate immune system is activated to fight the infection that comes with it, the dead tissue that's released, and this is an over-response There's bystander injury from this inflammatory response as shown here. It leads to multiple organ failure or multiple organ injury, which then usually recovers. And then you have immunosuppression, which leads to secondary infections, as we see in the ICU over and over again with pneumonia and other problems, wound infections. Then this heightened response occurs again with inflammation, secondary injury to the organs, a worsening of the organ dysfunction, and a significant increased mortality. And it leads to this disease with the patients we used to have in the ICU over and over again, multiple injuries, multiple organs failing in sequence, and a very poor outcome. So something has changed over the last 10 to 15 years, so it's really enabled us to have a better insight into what's going on in these patients, is the vast advances that have been made in genomics and genetic technology. Nature, 10 to 15 years ago now, we were able to clone the entire human genome. Projects such as the HapMat project allowed us to rapidly link genetic changes that occurred together on the same haplotype that allowed us to predict outcomes. And lastly, the increase in technology using DNA microarrays that allow us to actually measure what the genes are doing in various disease states. And where most of us have seen this explode is in the surgical oncologic arena. It goes all the way from one gene, BRCA, to up to 24 genes that are mutated, changed, their activity can be measured, can be related not only the progression of the disease, the response to therapy, and have allowed a great increase in precision treatment for the patient specific to their tumor. I'd like to show you in the setting of the trauma patients, we were able to use these same techniques, which instead of going from the top down, which is looking at the sick patient in the ICU and then sequentially trying to figure out what the neutrophils are doing, what the oxidant system in the neutrophil is doing, and going down to deeper and deeper layers, we now have the technology to start at the bottom. We can screen the proteomics, we can screen the genomics rapidly, repeatedly in the same patient, and it allows us then to construct how the various changes in the gene activity is relating to itself to change the way the cells are functioning, the way the organs are functioning, and the overall changes in patient activity and organ activity. So we took a large number of patients. In this case, we had 167 that I'm going to show you about that have been severely injured. Since we can't and we're not allowed to do biopsies of the liver serially in injured patients, we had to have access to a cell population, and we chose the white cells in the circulation as our surrogate to measure genomic changes. This is the trauma study. We looked at 1,600 patients from a physiologic standpoint, but we looked genomically at 167. They're severely injured. Sorry this isn't showing up very well, but their ISS was high. They had a mortality of 16% and multiple organ failure rate of over 30%. To get into the study, they had to be in shock. They had to have an elevated lactate and most likely to receive a blood transfusion in the first 24 hours. So they're blunt trauma, very sick patients. These patients were then looked at, and their genomic response was measured at less than 12 hours, 1 day, 4 days, 7 days, 14 and 28 days, or until they were discharged from the ICU to try and get a serial look at the response of these patients and how the genomic change was occurring. We used a standard edge technology because of the massive size of this data set. One of the problems with genomic analyses when you look at the entire genome is there's 20 to 40,000 genes measured on each chip. And unlike cancer, where the disease is fixed, these patients that are altered by their severe injury are therefore changing daily after the injury as they become better. And so the challenge in the data size alone is a major challenge. But what we're able to show is that looking at this, 80% of the human genome after this major blunt trauma was altered significant enough to be measured by the gene chips. 80%. Not one gene, not two genes, not 12 genes, but 80% of the 20,000 genes. Over 16,000 genes had significant alteration after major blunt trauma. If you increase that change to 1.5, it drops to 10,000 genes, and we arbitrarily looked at genes that were changed greater than twofold. Again, is there any science saying that greater than twofold is magic and important? No. But we had to arbitrarily decide a point, and as we usually do with biologic changes, we consider larger changes more likely to be significant than smaller changes. So we looked at the genes that had greater than twofold change identified by the analysis. And these are the 5,000 genes that change greater than twofold after severe blunt trauma. And those of you who aren't used to looking at heat maps, although most of us are anymore, these are the control patients on the left column, and then this is the different time periods after injury going from left to right. Each line is a separate gene. And so these 5,000 genes, you can see there's sort of two large groups. One is the upper group, which is normally blue, is downregulated activity. So these genes normally are downregulated. After severe injury, they become red, which means they have increased activity. It's markedly changed immediately after the injury, and then over the 28 days, there's a slow return towards normal, which is blue. Down here, about 2/3 of the genes that are normally upregulated do the opposite. They turn blue, which means they're turned off, and then they slowly return to normal over 28 days. The other thing that's interesting is you can sort of see highlights. Right here you can see a little group that's predominantly blue, and then at 7 to 10 days, all of a sudden it becomes red. And if you're as old as I am, as we were looking at these patients initially in the ICU, we used to see gamma globulins, IgM and IgG, used to spike at day 7 to 10. And we never knew what it was for. It was considered useless gamma globulin because it really wasn't focused on any treatment or endogenous response. But on this genomic response, you can see clearly that it's happening and that there's a big spike in the production of IgM and IgG. Again, we still don't know why at day 7. But one of the things that's interesting is, as my paradigm predicted, this upper third is the innate immune system pathways. These are the inflammatory pathways. These are ones that produce the TNF, the IL-1, the IL-6 that you always hear about, that causes a massive total body inflammatory response. This is what's thought to cause the organ injury by bystander injury by activating this innate immune system. What was interesting and had not been recognized before, though, is at the bottom 2/3, and if you look at the pathways involved, it's the adaptive immune response. It's the T cell responding to secondary infectious challenge. It's what the body has to turn on to create optimal healing conditions so that you don't get wound breakdowns, so that you don't get wound infections. And this, again, was unknown. It was not in the paradigm that over half of the change was not upregulation. It was actually suppression from the earliest time point in the adaptive immune response. And if you look at it from a purely pragmatic standpoint, this is why these patients that are so suppressed all develop nosocomial infections. It also allows us to identify the patients that are most likely to develop these infections and allow us to focus treatment on these patients, which I'll get to in a moment. It also allows us to tell the payers and the government that you can't eliminate infections in these patients to zero. They are genetically programmed to get an infection. And so we need to have better understanding for treatment and also the practicality of recognizing that some complications are not avoidable. Looking further at the proteins that come from these upregulated genes, this just confirms that these genes are not only upregulated, but they're actually producing protein. It's functional genetic activity. And then if you start looking at the patterns of these genes and proteins and their impact on the cells, you start to see interesting things. This is the TLR receptors. They're on neutrophils, macrophages, T cells. They're the receptors on these cells that recognize various foreign proteins and cause an immunologic response. And as you can see, many of these proteins, red again is upregulated, blue is downregulated. Most of these are upregulated. The body senses the need to be ready for bacterial invasion. There's a lot of broken down necrotic ischemic tissue that needs to be phagocytized and cleared so that wounds can heal. It's the immediate innate response of the body to optimize recovery. Again, though, what's interesting is if you look at this receptor here, which is in blue, it's the viral receptor. So again, if you look at these sick patients, 30 years ago when I started in the ICU, we didn't understand, and it's been increasingly studied over the years, why these critically ill, previously healthy people after severe injury all get reactivation of their CMV infections and other chronic basic viral infections. And again, this helps explain that from an immunologic standpoint, surveillance is turned off. And these patients get a recurrence of CMV and viral complications. And again, it focuses where we may need to treat. If you look at the monocyte function, which is critically important, this is looking at the pathways in the monocyte that are activated by gamma interferon. And as you can see, virtually every gene in this pathway in the monocyte is turned off. And this is actually what Hiram Polk showed us in 1970, that these genes, expression of HLDR, the ability to respond to an infectious challenge is immunosuppressed and leads to many of the complications. Here at the genomic level is demonstrating how correct Dr. Polk was and how extensive this downregulation in the immune cells is. The ability to respond to an infectious challenge is virtually turned off. And then other things, many of the residents know when you're working in the ICU, you have certain patients that you just keep giving insulin to, and their glucose just doesn't want to budge. They just stay hyperglycemic. You're giving them enormous doses. This looks at the insulin response system, which is required to take up glucose. And this is after a blood transfusion. If you look at these cells, there's a marked, again, blue is downregulation of the insulin receptor on the cell surface and all the secondary mechanisms necessary in response to the insulin to uptake glucose and to metabolize glucose. So again, at a genomic level, after severe injury, the insulin receptor is turned off and response to insulin is virtually zero, which we see in these patients where they are so insulin resistant, you just don't understand it, but genomically it's quite clear why they're not able to respond. And it lasts a long time. On the left is the ability of monocytes to phagocytose. The normal is shown here in this pattern of uptake on the flow diameter, flow study, whereas in these patients after severe injury, 45 days out, then they still cannot phagocytose bacteria. Similarly, if you look at the T cells, at 28 days, they're unable to express T cell antigens that are necessary, again, for a response of the immune system. So that's why when the patients go home, they're still susceptible. As our patient population gets older, we get these patients through their acute problem. We're excellent at keeping them alive through the ICU and well enough. We send them to the nursing home, and they're all dead within 6 months. The impact of the disease is still there. And when in a lesser support system, such as a nursing home, they have poor outcomes and poor complications. So we wanted to try and see if we could use these changes in the genome to try and identify patients and try and direct, again, our treatment to add a bit of precision to how we separate one person who's hit by a truck from another person who's hit by a truck. Because if you look at their physiology, they look identical. And yet one patient will do well, as shown here. The red bars are multiple organ failure. Some of these patients up here hit by the same truck, their lungs clear up, they get extubated, they get out of the ICU in 5 days. The patient with the same injury and the same initial physiology down here has multiple organ failure 4 weeks later. So the question we had is, can we use our information to help guide us as to which patient is going to be there 4 weeks as compared to 4 days? And so we used time to recovery, less than 5 days, greater than 10 days, to create 2 groups of patients, and then we looked to see if their genomic response was different in the 2 groups. And what we showed here was, if you look at the innate immune, which is mostly upregulation, as you can see here, and then the heat map shows maybe there's a difference between the 2 groups, no complications, but if you stratify it in this cartoon and map out the individual patients, you can see the green line are the patients that don't have complications. And those in the gray line or upper line are the ones who have complications. This data points out 2 things. One, if you look at the immediate response, they look very similar. And that's why if you measure these proteins immediately after an injury, they don't help predict how the patient's going to do. We spent billions of dollars in studies looking at trying to find a protein that's going to tell us which patient's going to get sick, which isn't. IL-6, TNF, pick one. But they all go up. There is none that goes up in the sick patients and down in the patients that don't get sick. They both go up. And they're virtually the same, so there's no discrimination power of those proteins. The difference is the patients that get complications don't get well, whereas those who don't have complications much more rapidly return towards baseline function. It's called homeostasis. The patients that are able to homeostase, return towards baseline, don't have complications. The ones who can't get complications. And if you think about it, working in ICUs, the patients who do the best after horrendous trauma are the ones who homeostase the best. And just generically, who is that? Kids. It's amazing what you can put a 5-year-old through and they just bounce back because they homeostase evolutionarily probably so much better than even you 20-year-olds. And when you get to my age, you might as well just throw yourself back in front of the next truck. Because we don't homeostase. And then if you look at the suppression, it's the same thing. The immunosuppression, it comes back towards normal quickly, does not have complication. The ones who don't do. And this just expands it into various groups that tend to move together, and you get the same pattern of delay. We took this then down to the genes that were greater than 2-fold difference between the patients who had complications and those who didn't. And we came up with 63 genes that were differentially expressed. And these are those 63 genes. Again, some are upregulated, they're normally turned off. And you can see here much more clearly the ones who have complications and those who don't both upregulate. They both become red. But look at the difference in the extent of the upregulation in the groups who have complications. Same thing here. Downregulation is much more marked in the patients who have complications than those who don't. And by 14 days, the patients without complications are all returned to normal function, whereas these take 28 days and more to return. And again, the cartoon shows you that effect more visually. And if you take each of these 63 genes and compare it to its control normal or the non-complicated match pair, it magnifies it even more. They both go up initially, then those who get sick keep going up, those who don't have complications return to normal. And we're currently in the middle of a study where we have 150 patients between us and the University of Florida, where we're looking at nanostring technology, where at the bedside we can measure these 63 genes serially over the early part of their care to see if we can prove our hypothesis that using this panel of 63 genes and nanotechnology, which was developed in the oncologic arena to look at the pattern of genetic mutations in our cancer patients, and use that information to say, this patient's going to have many complications, we need to start intervening on him early. And if you look at the predictability in this retrospective study, it is better than any current clinical score or predictive model that we have. It's much better than ISS, NISS, any predictive score you want. This data from the genomic level is much better. And if you look further out at the time of discharge, these are normal patients. These are the patients that are still sick, and these that are getting complications, and these that are closer to normal are the ones that are not. And again, if you take it way out, and the burn patients allowed us, as you know, the burn patient has metabolic changes for at least a year after a significant burn. You can see the genomic changes last for a year in these patients. So we can identify where the problems are and where to focus our treatment. Last, I just want to wrap up to make this a little more generic for most of you in the audience who don't do trauma every day. These studies, obviously, we didn't have the patient before they got hit by the truck. But we do have a patient population that is somewhat traumatized, that we do have access to them before that, and that is the major surgical patient. And actually, this study was done at the University of Miami. They took 24 patients, and they used Whipples and esophagectomies as a surgeon-induced attack to see how it looked on a genomic level and impact on the patient. So this was major thoracoabdominal surgery. They took the blood samples before and after. They did a similar analysis that we did on the trauma patients. They used greater than twofold change as being relevant. And the new gene chips in just the last 5 years are now twice as many genes being monitored, but they came up with exactly the same measurable impact. 80% of the genome is changed when you put a patient through a Whipple. 80%, 8 out of every 10 genes is impacted by that Whipple. But if you look at the ones that were significantly altered, greater than twofold, as I mentioned, we had 5,000 in severe trauma. In the Whipple and the esophagectomy patient, they found 500 were significantly changed. So you can say a Whipple is 10% of being hit by an ice cream truck. That's kind of simplistic, but that's the way to look at it. And if you do it laparoscopically, it's probably much less than that. I don't know. We don't have any data on that yet. But open Whipple is 10% of being hit by a truck. That's where you can tell your patient about that pre-op. It's like being hit by a small truck. And again, this is how they displayed it. These are the twofold differences. On the left are the ones that are upregulated, and on the right they're downregulated, or other way around. What's interesting is they looked at the upregulated pathways, same ones, innate inflammation, you would expect that. It's an insult. The body's innate immune system has one response. It upregulates in defense of the body. What's interesting on the downregulation are some things that are starting to turn up. As you can see here, the greater than twofold downregulated are the PD checkpoint gene pathway, which I find fascinating. So if we can start looking at these patients after their Whipple and see that their checkpoint pathways are altered and downregulated, we are already in a current study looking at treating sepsis with anti-PD-1. We may want to treat these patients that show an over-alteration in their PD checkpoint and treat them as a potential explanation as to why some patients get early recurrence, other patients don't. We may start to be seeing from a surgical perioperative point of view how we can provide better precision care of our individual patients using this genomic data as we go forward. And this is, again, broad spectrum genomics. This is not focusing down on the one gene that's aberrant in the cancer, but the host response to the trauma of a major operation. So again, the pathway is well defined. Hopefully we can use this going forward. The paradigm we used for 30 years is wrong. It's not upregulation, secondary downregulation, trying to turn off the response, and then a secondary upregulation. The response is rather one of the innate response is upregulated, the adaptive response is downregulated, which accounts for all the complications that we see in these patients, and a way for us to focus our therapy. And so again, the patient able to achieve homeostasis wins, and we need to figure out the right patient to give the right therapy as we move forward. Again, I thank you for your attention. I wanted to show you a mountain before I left. Some of you may have forgotten, but I greatly appreciate the honor of giving the lecture and your attention. Thank you.